No, sir.
Hmm.
40 is luckily today one case only completed.
Okay.
Good evening, respected professor and my dear students. I welcome you to the 22nd session of VISA online academic activities with me, our students. Today we have two important case discussions, one on renal transplant, other on lumbar spine anesthesia for lumbar spine surgery. I request professor and students to take over.
Yeah.
Good
Which
evening,
person
sir.
discuss?
Myself, sir.
Yeah, go ahead.
My case scenario is a 45 years old DM patient on thrice weekly hemodialysis posted for deceased donor kidney transplant, sir.
Okay.
First, chronic kidney disease. Chronic kidney disease is defined as abnormality of kidney structure or function present for more than 3 months with implications for health. The criteria for chronic kidney disease includes either of the following for more than 3 months. Albuminuria, more than 30 milligram per 24 hours, urine sediment abnormalities, electrolyte and other abnormalities due to tubular disorders, and abnormalities detected by histology, structural abnormalities detected by imaging, and history of kidney transplantation. Classification of CKD. CKDs are classified according to the following categories using glomerular filtration rate. GFR category stage 1, more than 90 ml per minute per 1.73 meter square area, which is normal or high. Stage 2, grade 2, GFR of 60 to 89 ml per minute per 1.73 meter square area, which is mildly decreased. Grade 3A, 45 to 59 ml per minute per 1.73 meter square area, which is mild to moderately decreased. Grade 3B, 30 to 44 ml per minute per 1.73 meter square area, which is moderately to severely decreased. Grade 4, 15 to 29 ml per minute per 1.73 meter square area, which is severely decreased. Grade 5 is less than 15 ml per minute per 1.73 meter square area, which is kidney failure. Categories of albuminuria: A1, A2, and A3. A1 is less than 30 milligram per 24 hours. A2 is 30 to 300 milligram per 24 hours, which is moderately increased. A3 is more than 300 milligram per 24 hours, which is severely increased. End-stage renal disease. End-stage renal disease is a clinical syndrome characterized by renal dysfunction that would prove fatal without renal replacement therapy, that is dialysis or renal transplantation. GFR of less than 15 ml per minute per 1.73 meter square area indicates end-stage renal disease. It includes the CKD stages of grade 4 and grade 5. Evaluation of GFR. GFR is used evaluated using endogenous filtration markers using serum creatinine and GFR estimating equation. Cockcroft-Grant formula gives a creatinine clearance, which is 140 minus age into weight in kg by plasma creatinine in milligram per deciliter into 72. Causes of CKD, which includes glomerulopathies like diabetes mellitus, membranoproliferative glomerulonephritis, post-infective glomerulonephritis, IgA nephropathy, SLE, and amyloidosis, and tubulointerstitial disease such as analgesic nephropathy, reflux nephropathy with pyelonephritis, myeloma kidney, and sarcoidosis. Other causes include systemic hypertension, polycystic kidney disease, renal vascular disease, and obstructive uropathy. Anesthetic management of a patient with CKD for renal transplant. The source of donor organ can be a deceased donor or a living donor. The deceased donor can be a brainstem dead heart beating donor or non-heart beating donor. The types of deceased donor includes standard criteria donor, donation after cardiac death, or extended criteria donor. The preservation of a deceased donor kidney, which is preserved in static cold storage of at about 0 to 4 degrees Celsius. It is immersed in preservative solution. Hypothermic environment decreases the cellular metabolism, and preservative solution decreases metabolism and provides cytoreduction. The preservative solutions include choline solution, urocholine solution, University of Wisconsin solution, and can be kept for 24 to 48 hours. Donor recipient matching. Matching has to be done between donor and the recipient to ensure the immunological compatibility. ABO compatibility, blood group matching to be done. Tissue matching with MHC6 antigen match represents the best compatibility. Cross matching between the recipient serum and the donor T cells to detect the presence of antibodies in the recipient against the donor cells. Contraindications for renal transplant include absolute contraindications and relative contraindications. Absolute contraindications are active infections, active malignancy, active substance abuse, reversible kidney failure, uncontrolled psychiatric disease, predicted patient survival of less than 2 years. Relative contraindications include systemic conditions that may cause kidney failure, like systemic amyloidosis with cardiac involvement. In cardiac cases, history of MI in the past 3 to 6 months, progressive symptoms of angina not amenable to angioplasty or bypass surgery, severe CAD not amenable to intervention, severe ischemic cardiomyopathy, pulmonary involvement like home O2 requirement, uncontrolled asthma, severe col pulmonale, severe COPD, fibrosis, and restrictive disease are related contraindications of renal transplant. Anesthetic management of a renal transplant patient. Pre-anesthetic assessment, which includes a history of symptoms of breathlessness, pedal edema, chest pain, palpitations, functional capacity, excessive tolerance is decreased or not. Cause and duration of CKD should to be mentioned, and history of diabetes, hypertension, CAD, and usual daily urine output intake, input output should be asked to if there is any residual renal function. Medications like antihypertensives such as AC inhibitors, ARBs, or diuretics, or calcium channel blockers, beta blockers to be mentioned. Bicarbonate level should be checked. Dialysis details should be obtained, which type of dialysis, like peritoneal dialysis or hemodialysis, and the site of AV fistula should be noted, and the duration of dialysis to be noted, and the frequency like once or thrice weekly to be mentioned, and the time of last dialysis to be mentioned, and the body weight before and after dialysis to be mentioned, and dialysis is heparinized or not to be mentioned. On examination regarding to be done for pallor, bleeding tendency, edema, fluid overload, vital signs of to be noted for hypertension, check for autonomic neuropathy, in CVS, flow murmurs to be noted, in RS, crepitations to be noted for in case of fluid overload and the need for dialysis, location of AV fistula to be noted, and the dialysis lines to be noted, airway assessment to be done. Investigations. Pre-op investigations include CBC to rule out anemia, and a WBC to rule out infections and platelet count, RFT and electrolytes, which includes serum creatinine, sodium, potassium, calcium, bicarb, coagulation profile like PT-INR and PTT, chest X-ray to rule out cardiomegaly, pulmonary edema, and pleural effusion, ECGs for arrhythmias, ischemia, and conduction blocks or hyperkalemia to be noted, echo for noting any regional wall motion abnormality, or EF or pericardial effusion. Pre-op preparation and pre-medication, informed consent to be obtained, and NPO status is verified, CBC and serum electrolytes and blood glucose levels on the day of surgery to be obtained, vascular access, 2 large bore venous access to be secured, and the site of AV fistula is avoided for IV access, at least 2 units of pre-RBC to be reserved and cross-matched. Pre-medication, IV midazolam of 0.5 milligram at titrated doses to anxiolytic effect, and anti-aspiration therapy can be given. Sodium citrate 500 mg in 15 ml can be given, and H2 receptor antagonist like cimetidine or famotidine can be used. Antibiotic prophylaxis to be given 30 to 60 minutes prior to surgical incision. Most commonly used antibiotics are first generation cephalosporins. The choice of anesthetic technique include general anesthesia, which is most commonly preferred. Neuraxial anesthesia is mostly avoided due to uremic platelet dysfunction and residual heparin function post dialysis. Monitors used are pulse oximetry, NABP cuff to be avoided in the hand of AV fistula, ECG, temperature, urine output, pre-grafting and post-grafting to be monitored, and invasive BP monitoring and central venous pressure monitoring can be done. Induction, adequate pre-oxygenation. IV propofol of 1 to 2 milligram per kg is preferred induction agent and is administered at titrated doses. Fentanyl of 1 mg per kg. Neuromuscular blockade using atracurium of 0.5 mg per kg or cis atracurium of 0.2 mg per kg can be done. Intubation response can be avoided by using IV lignocaine of 1.5 milligram per kg. Rapid sequence induction is used in patients at a high risk of aspiration. Choline can be used if serum potassium is less than 5.5 milliequivalents per liter. When the serum potassium is more than 5.5 milliequivalents per liter, then rocuronium can be used instead of succinylcholine. Careful positioning with padding of the pressure points. AV fistula is carefully protected to avoid pressure. The fistula site pressure can lead to fistula thrombosis. Maintenance of anesthesia is done using oxygen, air, and isoflurane. Opioids like fentanyl with 1 mg per kg. Avoid morphine or pethidine. Neuromuscular blockade with atracurium of 0.1 mg per kg. Heparin 5000 international units may be given prior to clamping of the blood vessels. Diuretic therapy used prior to allograft reperfusion to decrease the incidence of acute tubular necrosis and to promote diuresis. Commonly used is mannitol, which increases renal blood flow by increasing the prostaglandins. Immunosuppressive induction can be given, glucocorticoids, as a bolus before reperfusion. Methylprednisolone 500 mg to 1 gram IV is given. Ischemia time. Ischemia time is of warm ischemia time and cold ischemia time. Warm ischemia time is for living kidney donors, which has two phases. Warm ischemia time starts from clamping of the donor vessels to the infusion of the preservative solution. And the second phase starts from the placement of the donor kidney in the recipient to the reperfusion following vascular anastomosis. Increased warm ischemia time increases the risk of acute tubular necrosis in the postoperative period. Cold ischemia time is for deceased kidney donor, which starts from the time of preservation of a donor kidney in the preservative fluid to the release of a vascular clamp following completion of anastomosis. Longer the cold ischemia time, poorer the graft function. The cold ischemia time should be restricted to 24 hours. Maintaining the hemodynamics, MAP should be maintained at 60 to 80 millimeter of mercury prior to vascular anastomosis. Following renal reperfusion, MAP should be at 70 to 90 millimeter of mercury. If the patient is preoperatively hypertensive, then MAP should be maintained above 90 millimeter of mercury. Urine output should be gold at more than 0.5 ml per kg per hour intraoperatively. Intraoliguria may be due to reduced allograft perfusion or hypovolemia, ureteral obstruction or vascular thrombosis. Intra blood sugar to be maintained at 140 to 180 milligram per deciliter. If more than 180 milligram per deciliter, then insulin infusion can be started. Avoid hypothermia using forced air warmers and fluid warmers. The ventilation is done using protective lung ventilation. Tidal volume at 6 to 7 ml per kg. PEEP at 5 centimeter of water with airway pressure of less than 40 centimeter water and a plateau pressure of less than 30 centimeter of water. Extubation after ensure is done immediately after post-op, after ensuring normothermia, adequate tidal volume, adequate neuromuscular blockade reversal, full consciousness. In case of delayed recovery or fluid overload causing pulmonary edema and delayed graft function, then post-op elective post-op ventilation is continued. Post-operative care is done using dedicated post-transplant unit. Fluid management includes last hour urine output plus 50 ml per hour based on CVP, BP, and body weight. Hemodynamic management is done. Hypotension is associated with delayed graft function. Analgesia includes patient control anesthesia with opioids like fentanyl and morphine. Epidural can be given at T12 L1 level. Transversus abdominis plain blocks can be given. Avoid NSAIDs. Monitoring urine output, renal function tests, and electrolytes. To continue immunosuppressive medications, thromboprophylaxis can be given. Early mobilization and mechanical thromboprophylaxis can be given. Post-op complications include wound infection, hematoma, pulmonary edema, acute graft rejection, renal artery or vein thrombosis, urinary complications, and delayed graft function. The delayed graft function is that failure of the transplanted kidney to function promptly after transplantation, leading to dialysis within 1 week after transplant. It can be due to hemodynamic or immunological process. Acute tubular necrosis is the most common cause of delayed graft function, which may be due to deceased donor kidney already injured or prolonged warm or cold ischemia time, hemodynamic status of the recipient during transplantation, and it may be due to reperfusion injury.
Finished?
Thank you, sir. Yes, sir.
Okay, very good. You have covered most of the important points.
Yes, sir.
See, when any topic, when we try to learn, there are three methods rather, I would say. One is studying the entire topic for your good knowledge about the topic. Okay, knowing the in and out of the topic, to read it in detail for your to have a very strong basic concept about that particular topic, both for your practice point of view and for your understanding the topic. That is one way of reading. The second is preparing a topic for presenting in a theory question exam paper. Third is preparing the topic for viva or practical exam purpose. Now, this question which I have framed and asked you, a 45-year-old diabetic of 15 years duration, who is on thrice weekly hemodialysis, now waiting for a deceased donor kidney transplantation because of already he has gone on renal replacement therapy in the form of hemodialysis. So this worded question, do you think it is a viva question, or is it a theory question, or it is a question where you have to read about and improve your knowledge? The first thing I told you is to have a sound basic knowledge of any topic that we read is for our own purpose. To become a good doctor with good knowledge, we have to read the topic in depth and understand it fully so that we can update on the basic concept with the newer things that are happening and improve our knowledge. That is one way of learning. Okay. The second way is to prepare your topic for writing a theory answer within the 20 minutes time that you are given to present that answer. The third is to prepare yourself to face the questions from the examiner so that you can answer all the questions that they can ask you. So these are the three ways in which you have to learn any topic, not only the CKD, but any topic in anesthesia. This is what I feel that every PG should aim to study and learn. So now what you have prepared and written is ideal for a theory answering method. Okay, if this same scenario is asked in the theory exam, your answer will be very perfectly suitable for that particular question, way of answer. But if this is given as a Viva in the practical, if a real patient who is having AV fistula undergoing thrice weekly hemodialysis is brought and kept as a live patient for you to examine and then take the history and then come to the diagnosis and then make a general examination of the patient, find out the clinical findings, signs and symptoms, and then go on with the examiner for the discussion of how to manage the topic, it becomes an entirely different scenario. Okay. So now we will go on to discuss this as a Viva or practical exam question rather than a theory question. Okay.
Okay.
So if it is a Viva question where the patient is given to you, can you just recall what you have written and then tell me what are all the points you have to ask in this patient? Now I am giving you a patient, 45-year-old patient has been kept in the exam and you are asked to take that. The lot has been allotted to you. You go and see patient, you don't know the diagnosis. Okay, a 45-year-old man who has a very prominent AV fistula. How will you identify that the patient has an AV fistula? By looking at the limb of the patient.
There will be.
Have you ever seen a patient with AV fistula? Have you seen a renal transplant being done in your hospital?
Yes, sir.
Yes. Okay. So can you identify whether a patient has a AV fistula or not by just looking at his upper limb or whichever limb they have created an AV fistula? Is it will it be visible
fistula,
obviously? Huh?
the site of fistula will be visible.
As a, how will it be just seen as a scar or something else will be very prominently seen?
The fistula site will be bulging out.
You have a tortuous visible veins.
Yes,
okay.
Yes.
Why those veins become very visible and tortuous?
Because of a continuous flow.
Continuous flow from
artery to the vein.
Artery to the vein. So why the veins should become tortuous? That is the question. What is the pressure in the veins normally? Low or high?
Low.
Veins are low pressure systems, isn't it?
Yes, sir.
But you are allowing the arterial blood with a high pressure to flow into the venous system. Okay. So will what is the nature of the veins wall? Is it a very thin wall or a very strong walled structure?
Veins are thin walled.
Thin walled. Okay. By repeated flow of high pressure blood, what will happen to this venous wall? They will start increasing in size because they are stretched in size. Okay, they get stretched over a period of time and they cannot burst. Then the patient will bleed to death. So they pass on the stress to the proximal segment, and whichever be the length of the whole vein, it becomes bulgier and bigger and bigger and becomes tortuous. Looks like a large worm or a snake flowing through the whole upper limb. Okay, so that is how the venous system. Is there any name for the change in the vein? It is happening because of the flow of the blood, arterial blood into that.
Arterialization of the vein.
Arterialization of the vein. It is very good. It is called arterialization of the vein. Okay. What is one complication that can happen because of this arterialization to that particular limb? Supposing you do an anastomosis at the wrist with the radial artery and cephalic vein, and over a period of time you find that the forearm veins are becoming bulged out, tortuous, and they were very easily visible. What can happen to the limb, left limb, after some time, which is not a very common thing to happen, but one important
Lengthening will increase, sir. That
gigantism.
Length of the upper limb will increase.
not length. It will increase in size. It will become
Size.
bigger. Okay.
Yes, sir. Yes,
So
sir.
the fingers may become very huge, bulged out. That is called gigantism of the limb. Because of increased blood flow to the capillary system, more nutrition is available that will be taken and the tissues start growing. In some patients, the whole hand and fingers, they all increase in size enormously. And that is called gigantism of the limb. Okay. And why do you want to create this AV fistula? What is the purpose of creating AV fistula for hemodialysis?
Oh.
What do you want to do in hemodialysis?
So, to reduce the fluid overload and
So
to remove
have you ever gone to the
electrolyte.
nephrology unit where dialysis is being done, and have you ever seen a patient undergoing dialysis?
Yes, sir.
See, all these things you
Regular
should go and
dialysis.
sit with the patient and see how they are performing this. Okay, this is very, very important knowledge that you can gain by visiting the dialysis section and then observing the patient or asking the senior sisters in charge there what are all the things they do. So that knowledge will help you to understand the subject much better than just reading the books. Okay, you will get a lot of information by going there. You can observe the protocol they follow. You know what are all the things that routinely will be done in any dialysis unit. For example, this 45-year-old man is due for dialysis today. He comes to the dialysis room. You know what are all the things that will be done to him? Soundarya or
Yes, sir.
Sivatano, Muthupriya, any one of you can answer. It is not necessary that Siva Shankari alone should answer that. What is the first thing they will do to the patient when he
Weight.
comes? He will be weighed in the vestibular. So what is that weight called? It is called pre-dialysis weight. And they will carry always a notebook. Have you ever seen that the
Yes, sir.
hemodialysis patient coming to the hospital? Okay. So
Yes,
they
sir.
will put the date, weigh the patient, measure and record the pre-dialysis weight. Then what is the next thing they will do?
Check the patency of.
How much fluid they have to drain?
Okay, that is from the weight they can decide. But what you must be able to tell me what are all the steps through which the patient will go through in a dialysis unit. First thing, they will measure the weight of the patient. What is the second thing that they will do? Why do you want to do the dialysis? One is to remove the fluid. Second, what is the other things
Toxic
that you want
products,
to
sir.
remove? You want to
remove
remove
the
the
toxins,
creatinine, urea, and
electrolytes.
other things. So you will take a blood sample, send it for urea,
Baseline.
creatinine, electrolytes. Okay, that is the second step that they will do. Okay, then they will make the patient lie in the couch or the bed near the dialysis machine, and then insert 2 needles in the venous system, which has bulged out and tortuously, very easily visible. They will insert 1 needle for draining the blood and another needle for returning the blood. Okay, under aseptic precautions that will be done, and that needles will be fixed there, and it will be connected to the dialysis machine. How much ml of blood will be drawn per minute?
5.
Again, it depends on how much fluid you want to take out of the patient or reduce the weight. Okay, it is the 300 to 500 ml per minute is the drawing of the blood. So that means for 1 minute, if you draw 300 to 500 ml, for 1 hour you will draw into 60, isn't it? 1800 to 3000 ml you can draw. Okay, that is what you will do, and that blood will go to the dialysis machine where that will be. Suppose we have talked about renal replacement therapy in an earlier class, where there will be a dialysis or the kidney filter will be there, where there by counter current metabolism. That is the reason why we have seen in one of the ASCIIs why it is called the artificial kidney, because the counter current mechanism which is followed in the Normal kidney is followed in the filter of the dialysis machine also. Blood goes in one direction, the dialysis fluid goes in an opposite direction, and both by convection and filtration, diffusion, the unwanted things, fluids are all removed, and the purified blood is pumped back into the patient. Okay, this is the basic thing that is going to happen. After completing, say, 2 hours or 3 hours of the patient's dialysis, post dialysis, what are all the things that they will do?
They will weigh the patient again.
They will weigh the patient and find out how much weight reduction has been achieved. Okay, and then what is the other thing? They took the blood sample before starting the dialysis. Do they have to check the blood again?
Yes, sir.
Yes. So they have to take another blood sample and send it to the lab to find out the values, whether they have adequately removed the toxins or the unwanted metabolites also. Okay. So this is all the things that will be followed. So here, if supposing the first day the patient goes for hemodialysis, what are all the problems he can face? To suddenly take 300 to 500 ml of blood from the patient who has not had a dialysis before, what are all the complications or the difficulties the patient can face?
Hypovolemia.
Hypotension.
He may not tolerate that removal. His cardiovascular system sometimes may not be able to tolerate the removal of such fluid in the such fast rate. Okay.
Yes,
So
sir.
that may cause problem. What is the name for that situation where you draw the blood, suddenly patient becomes hypotensive, then you try to stop the dialysis and resuscitate the patient with some IV fluids, and patient says, my head is aching, I have some seizure activity like thing, or I feel drowsy. What is that called?
Dialysis disequilibrium syndrome.
Dialysis
Disequilibrium syndrome.
Okay, so that history is very, very important. So whenever you ask the history of the patient, you must ask them why he was started on hemodialysis, what were the values of his blood at the time of starting the dialysis. So what are the indications for hemodialysis or renal replacement therapy? What are the parameters by which you decide that this patient has to go on for dialysis?
Any fluid overload.
Very good. Fluid overload with pulmonary edema.
Pulmonary edema.
Difficulty in breathing. Excellent one. Then
Any acute intoxications, sir?
acute intoxication. What is intoxication?
Any poisoning or any lithium overdose?
Lithium.
Yes, sir.
No. I'm asking in a end-stage renal disease patient, what are the indications to start them on renal
Diabetic
treatment?
glomerulonephropathy.
Hyperkalemia.
No, diabetic glomerulonephritis is the pathology.
Okay, sir.
I think my question is not worded properly. See, a 45-year-old diabetic patient of 15 years who has gradually got reduced GFR has come to grade 4 or grade 5, as she said. What makes the nephrologist to decide that this patient now requires renal replacement therapy? What are all the investigatory or clinical parameters? One is fluid overload. Patient is not able to tolerate the fluid. He becomes swollen up everywhere. There is a facial edema, pedal edema, breathlessness, impending pulmonary edema is an excellent one of the important indications for immediate dialysis. It may be an acute dialysis, not through an AV fistula, but through a IJV cannula. But if they have time, the nephrologist, what are all the parameters by which the nephrologist will advise? See, your kidneys are failing. You require initially a renal replacement therapy. Later on, you may need a transplant. So what are all the parameters by which they decide that this patient should go for renal replacement therapy?
Metabolic acidosis, hyperkalemia.
ABG, acute metabolic acidosis. That is again an acute condition. I am asking about chronic indications. See, a patient
Encephalopathy.
Uremia.
Raised urea and creatinine. Okay, any creatinine value more than 4.5. Urea more than 100 with uremic features, okay, and GFR less than 15. All these three things or in impending pulmonary edema or a impending acute acidosis, metabolic acidosis. Okay, these are all the indications for the nephrologist to decide. If he is not got fluid overload, if he is not in acute acidosis, then the nephrologist may advise the patient to first to have an AV fistula created, provided he is still passing some amount of native urine, like say about 750 to 800 ml of urine is passing, and he is not having any impending fluid overload now, then the nephrologist will usually advise them to first undergo an AV fistula. Okay, that surgery has to be done. How soon after creating an AV fistula you can use it for hemodialysis? Very next day?
No, sir. 2 to 4 weeks gap, sir.
4 to 6
Why
weeks.
you have,
After 6 weeks.
you have to wait at least for minimum 4 weeks.
4
Okay,
weeks.
then only you can use it. Then only it will call maturing. Okay, so immediately after creating an AV fistula, what are the clinical evidences that the fistula is working well?
Bruit over the fistula.
Thrill and bruit. What is the difference between a thrill and bruit?
Thrill is palpable.
Excellent.
Bruit is
Thrill is palpable,
auscultation.
bruit is auscultation.
Auscultation.
Okay? Excellent. Very good. So that is the two things that you have to. You would have seen the vascular surgeon or the whoever surgeon performs the AV fistula will always first see for the thrill by palpating the distal portion or proximal portion of the vein. Then he will also auscultate over that area to find whether there is a bruit. That sound will come just like a murmur. Okay, so these are the two things to indicate that the fistula is working well, and that cannot be immediately used as it has to stabilize, and then after 4 weeks you can start. So these are all the questions that can be asked in your examination, in the practical examination, because the other things of discussion of renal replacement and renal transplant in CKD patients are all available thanks to Dr. Kamachi in the video form, and you would have all gone through that. I'm not planning to repeat it again today so that it will be a total repetition. Instead of that, I am planning to ask some practical questions which you can face in the examination so that you can answer that. Now, the second part of this case scenario is this patient, I told you, is a diabetic mellitus patient for 15 years and he has gone on to develop a CKD. Okay. Now, there are likely questions that can be asked. Why a diabetic patient develops a CKD? What is the pathophysiology? And is there a possibility of detecting whether a diabetic patient will become a kidney patient later on by any investigation at the very early stage of the development of this pathology?
Due to microangiopathy.
Microangiopathy. Okay. What is microangiopathy? What exactly is the change? Micro means small, angiopathy means small vessel disease. That is the overall pathophysiology that happens in any diabetic, macro and microvascular disease. That is how diabetes is defined as or described as. But in kidney, what exactly the change that is produced? What is the earliest indicator of a nephropathy in a diabetic patient?
Sir, increased glomerular filtration rate, sir.
Increased glomerular filtration. Will it once it is very good for the patient, isn't it?
Microalbuminuria, sir.
Microalbuminuria. Okay. So why normally microalbumin does not come into the urine? Why should it not normally come in a regular normal kidney function? You don't find albumin in the urine at all. If you see the normal urine analysis reports, they will say proteins nil, sugar nil. That is the value that are reporting that you expect for in a normal functioning kidney. But why normally albumin is not allowed to come into the urine? What is the mechanism in a normal physiology?
The albumin cannot pass through the pore in the glomerulus.
Glomerulus is a big structure. What are all the components of glomerulus? See, this is how they can
Different arterial.
the questions from your pathology to basic physiology before going to pathophysiology again. Okay, so you must have a sound knowledge of the basic physiology. So what are the components which form the glomerular filtration unit?
Sir, arteriole, Bowman's capsule, efferent arteriole, and that, here that's the endothelium, and that's a basement membrane followed by visceral sites.
So there is a vascular compartment on the above, there is a basement membrane, then the tubular beginning. These are the three important structures. Okay, you can compare it with any other structure in the central nervous system. Any filtering mechanism like this in the brain. Blood-brain barrier. Okay, so there also you have a vascular endothelium, you have a basement membrane, you have the astrocytes. Similar to that, here you have the vascular capillaries. Bowman's capsule, there is a capillary system with a endothelial lining, basement membrane, then the photocytes of the proximal convoluted tubule. Okay, so three structures are forming here. Of this, the basement membrane is the main filtering, because fluid seeps out from the capillary, comes into the interstitial space, passes through the basement membrane, then goes to the collecting system of the proximal convoluted tubule. This is how the whole filtration takes place. Now, why the basement membrane does not allow the proteins or albumin to come into the proximal convoluted tubule?
So it's negative charges, sir.
One is
Charge
negativity, yes. Both, there are negative charges in the basement membrane, and albumin also has a negative charge. So, like poles repel. So, the charges don't allow the albumin to come into the proximal convoluted tubule. Second, this is the first factor. Second factor,
size, sir.
molecular weight. Yes. So, what is the, how many Daltons is the size of the albumin?
40,000.
40 to 80 80,000 Daltons. Okay, so it is a big particle. So that is the second reason. But once the albumin is able to pass through that, what does it indicate? Is the basement membrane having a bone which is of very small size to prevent this albumin to come into the proximal convoluted tubule, or it has become leaky?
Become leaky.
It has become leaky. The pores have become more. So negative charges are overwhelmed by that, by the larger holes. Okay. So even though the negative charges are still maintained, the basement membrane, the pores have become wider, so they allow the albumin to pass through and come into that. In the initial stages, it comes in very small quantities, like 30 to 300 milligrams per day within 24 hours. Okay, it should be normally less than 30 milligrams per day. Okay, and the earliest indicator to show that, if you check for the microalbuminuria, if it is getting gradually increased, that is the first indication that this patient is going in for diabetic nephropathy. Okay? So there are, of course, other pathophysiologies, like also this is also called the glomerular sclerosis. In terms of pathology, it is also called glomerular sclerosis. That is how the whole pathology happens, and gradually patient loses its function. And what advice you should give a patient if he is having a slightly increased microalbumin values? What is the advice to be given to prevent him from going in for full-fledged nephropathy?
So first
Change
control
into
of
OHA 2
Huh?
Oral hypoglycemic agents, sir, to insulin.
Oral hypoglycemic
Hypoglycemic
agents.
agents will cause renal failure, so we'll change.
First
to
of all,
insulin.
Siva has correctly said, control the diabetes properly. Okay, that is the first and foremost. By dietary and lifestyle adjustments, first control the blood sugar value, then see what anti-diabetic agents are likely to cause this problem or aggravate this problem. Okay, so
Yes,
which
sir.
drug is notorious for that? Which oral
Metformin, sir, biguanides.
metformin? Yes, metformin. Long-term high dosage uses will definitely cause. Which is the safest oral hypoglycemic agent in a patient with diabetic nephropathy?
DPP4 inhibitors, linagliptins,
DPP4 inhibitors. Okay. Any sulfonylurea? which is
Alpha-nylurea.
glycoside, sir.
Lipicide.
Lipicide.
Lipicide is the safest oral sulfonylurea diabetic anti-diabetic agent. Okay. So these are all the things that you have to ask this patient in the history when it was diagnosed, why he was planned to go on, because 15 years of diabetes, he would have been in hemodialysis only for the last 4 months or 6 months or at the most 1 year. Okay, not all the 15 years he would have been on dialysis. So the problem develops later in life when the chronicity of diabetes is there and the uncontrolled state is there, then they will suffer from this particular problem. Okay, so this is the second aspect that you have to learn well for your practical exam. Now that this patient has been put on renal replacement therapy and he has been advised to go for a renal transplant for getting rid of the hassle of going in for thrice a week dialysis, going to the hospital, lying down in the bed and spending 3 to 4 hours in the hospital. It becomes quite expensive also. Every time they have to pay. Of course, government hospitals, they may do it free, but private hospitals, they may charge, and there are a lot of NGOs which do it at a very concessional rate. All these things are there, practicalities are there. But the permanent solution for this problem is undergoing a renal transplant, which will relieve him of all this problem. So as you rightly said, the transplant can be of two types. One is a related live donor transplantation or a deceased donor transplantation. Okay. So what is the difference between a live donation and a deceased donation? I'm asking about the practical conduct of transplant. If you want to do a live donor transplant, some close relatives is willing to donate the kidney for this patient, or a very close friend, even though they are not blood donor, I mean blood relatives, they are willing to give. Nowadays, that also can be done, arranged. So either a related or unrelated donor is available for this patient, and a live donor transplantation is formed. In what way it differs from a deceased donor transplantation?
Live will be elective and deceased
Very
will
good.
be urgent procedure.
Fantastic.
Emergency disease within 24 hours.
It may be quasi-emergency. Disease will be quasi-emergency, not immediate. They will have some time, because as soon as the donor is available, information will come to all the hospital that there is a patient who is willing to donate and we are going to start the harvesting. So if you have any patient, get them ready. So you have about 6 to 10 hours time will be there till the harvesting is done and the organ is transported to the particular institution. Before that, you can prepare the patient. But you won't have the normal luxurious time that you can decide that whatever time you want to take, you cannot do that. So it is called quasi or half emergency. Okay, that is the first difference. Very good. What other differences are there, Abraham, between a live donor transplantation and a deceased donor transplantation?
Matching.
Matching, yes, matching, and the matching will be done only, the information will come. If it is a deceased donor, the information will come. We are harvesting the organ from a patient with such and such blood group. So if you have a similar blood group, the recipient waiting, get them ready. That is the message that will come to the recipient hospital. So that is the same for living donor and the deceased donor. The first point she said is live related donor surgery is an elective procedure which is fixed at the convenience of everybody, whereas the deceased donor is a quasi emergency. That is the first point, I agree. What is the next thing? How do you perform the surgeries? Do you perform them simultaneously like a live donor, or it is different? Deceased donor.
Live donor will be simultaneously done.
Simultaneously. So what are the requirements to do the surgery simultaneously in the OT arrangement?
Adequate transplant team to be needed. For the
You
donor
need
side
to-
and the recipient.
Very good. You need 2 teams of surgeon, anesthetist, nurse, assistants, circulating nurse. So 2 teams should be ready. One for the donor, one for the recipient. As far as medical and paramedical people are concerned. Okay. What about the OT arrangement? Practical OT, how it should be? Can you do it in one block? You do the donor, and another block you can do the recipient.
No, sir, it should be
Yes.
Intercommunicating
intercommunicating
OT.
OT.
That is very important. It should be a twin theater with a communicating door between that. That is the usual arrangement, so that you can immediately bring the kidney from the next room and give it to the recipient area. Okay, so that is the second important. So 2 teams of doctors and nurses should be there, and that be a twin OT with an intercommunication facility. Okay, and that is how you start the surgery. Which surgery will be started first? Donor or the recipient?
Donor.
Donor. And
It depends on the
recipient will
speed and
also
skill of the surgeon. If both of the teams are very experienced, both can be started simultaneously. If one is a slow person, then that person should start first, and this faster person should join later. Okay, so that is not a big issue at all, right? So, how is it? You mentioned about warm ischemia, cold ischemia, and all these things. What is the preservative solution composition? That may sometimes be asked. You mentioned about urocolins, Wisconsin University solutions, all these things. What is the basic concept of this preservative solution? What do they do? Why do you have to preserve this? What are the purposes of using this preservative solution? What is the first purpose?
to reduce the cellular metabolism.
Is it the first and foremost thing? When you harvest the kidney from the
To
donor,
reduce
how will the
ischemia.
kidney look? Huh? Will it have some blood inside it, or it will not have any blood? When they clamp the renal artery and vein in the donor and cut the vessels and remove the kidney after dissection, will there be blood inside that kidney or not?
Yes, sir.
Yes, sir.
It will have blood inside, isn't it? So
Yes,
can
sir.
you directly put it in the recipient? By the time you put it, what will happen to the blood inside? It will clot, it will occlude the whole flow. So the first and foremost purpose of this preservative fluid is to flush out the blood inside the kidney. That is why immediately they will go and start pumping, because you have 5 to 6 minutes of clotting time. Within that, you must try to flush the kidney of all the blood. So when you take out the kidney from the donor, it will be looking normal pink color with all the blood inside. So how do you judge, or how do you decide that you have adequately flushed the kidney? What is the color of the kidney after you do a good perfusion? Have you ever stood by the side of the nephrologist or the perfusionist and seen what they do to the kidney when they do the transplant? Have you been allowed to see that?
Yes, sir.
You say, what will be the color of the kidney after they do the perfusion?
Pink.
You is still pink. You have flushed out all the blood.
Brown.
It will become almost pale because there is no blood in the kidney. The ideal way is to completely wash out all the. So when you put, will you put the blood into the, the perfusing fluid into the artery or in the vein? Inside the ice tray that they keep the kidney. You must go and watch all
Say
these
the
things.
vein.
When these surgeries are being done in the OT, you must watch everything, what is being done in that. They will have to put the preservative fluid into the artery, just like your artery being supplying the blood and vein doing the drainage. You must put the perfusing fluid in the same way. A small atraumatic cannula will be introduced into the renal artery, and the fluid will be flushed with a little pressure through a compression bag in a IV fluid bag will be there. Sorry. And that is the way they will try to flush out all the blood and then try to once again.
Yes, sir.
So the kidney has to look almost white without any blood. That is the first purpose. And what should be the temperature of the preservative fluid?
0 to 4 degrees Celsius.
4 degree, not 0 to 4, 4 degrees centigrade. Very good. So what are the components of the preservative fluid? Basically, what are all the things that are needed? Because now the kidney is going to be without blood supply for some time until the vascular anastomosis is done and reperfusion is established. It is going to be without blood supply. So to preserve the cell activity, what are all the things that are needed? It should be supplied by the preservative fluid. See, for the normal cellular metabolism, what are all the things that a cell needs, ma?
Glucose.
Glucose, ultimate energy. Actually, any cell to survive, it requires energy, which is in the form of ATP. Okay, that ATP can be produced by with oxygen or without oxygen, aerobic or anaerobic metabolism. Here, is it going to be anaerobic or aerobic?
Anaerobic.
Anaerobic. There is you cannot supply oxygen with the preservative fluid. So you can give the nutrient like the dextrose, but it will make its own ATP by only anaerobic metabolism. At the time, what is the excess unwanted thing that will be produced?
Lactate.
Lactate will be produced. What this lactate will do? Will it change? How will it change the pH?
Acidosis.
Acidosis, it will change. It will cause acidosis. So you have to counteract this acidosis. You have to supply the glucose and keep the cell at the low temperature so that the metabolic demand is not the normal. Okay, these are the three things that you have to take into consideration by using the preservative fluid. So it should contain some dextrose. It should contain some buffering agent to reduce the acidosis, and the temperature should be low to reduce the metabolic activity itself. And it should have some extra amount of potassium also for the cells to survive. So these four components should be there: dextrose, buffering system like Bitar, and potassium, and temperature of 4 degrees centigrade, whichever thing that you use. And sometimes you can add heparin to prevent further clotting inside, and you can add papaverine to keep the vessels dilated. All these things are optional, and these compositions are variable from institutions to institution. But you must understand the basic concept of usage of this preservative fluid. For any organ, this is the standard that you have to remember. Okay, so you keep it in the ice itself and then bring it to the recipient and anastomose and release the clamp. So what are all the problems of reperfusion? Once you fix the kidney in the recipient and release the clamps and allow the recipient blood to flow inside the kidney, what are all the indicators of a successful good anastomosis? Number one, what are all the problems that you have to anticipate during the reperfusion in the recipient? How will you know that this anastomosis has been done properly?
Urine output.
Urine output is okay, that's a functional thing, but appearance wise, what is the change you will see?
Change to pink.
The kidney has become pale and whitish when you have flushed out all the blood. Once you start perfusing it again with the blood, what should be the change in the color?
It should be pink.
It should again be pink. That is the basic thing, isn't it? It should, if the perfusion is good, if the anastomosis has been done well, if the pressure of the recipient blood pumping into the kidney should become turgid and pink. It should become hard and it should look very pink again, like how it looked in the donor before it was removed. The same consistency and same color should be the first thing, that change that you should see in the kidney. Then once if the function is also good with adequate flow, adequate fluid, adequate pressure, then the ureter will start jetting out the urine very nicely. You will see the flow on the table in a live donor transplantation. So these are the two things that indicate that the vascular surgeon or the urology, whoever does the vascular anastomosis, has done a very good job, because the kidney looks pink and turgid and there is immediate spontaneous spurt of urine from the cut end of the ureter. Will the same thing happen in a deceased donor kidney? Deceased donor, the color may be the change. The appearance will be correctly similar to the live donor transplantation, because you are allowing the blood to flow into the preserved deceased donor kidney. The change in the appearance will be the same. The pink color will come, the turgidity will come, but the spurt of urine from the cut end of the ureter is not guaranteed all the time. It may not, especially the more delay in receiving the organ for transplant from another center, say for 72 hours. Up to 72 hours, you can do the transplantation in a deceased donor program. So more the delay, lesser the chances of urine output on the table. So what is the important precaution you have to take in a deceased donor transplantation for the recipient? The clue is that he may not secrete adequate urine on the table. So what are
adequate hydration?
Adequate hydration is required for both, for the normal functioning of the kidney. Now the difference is, in live donor transplantation, majority of the time you expect the kidney to work on the table and produce a good spurt of urine. Whereas in deceased donor, this may take a little time. There may be a delayed starting of the function. So you may not get immediate urine output in the deceased donor kidney. So what are the precautions or post-op readiness that you should keep?
Diuretics.
Right. See, you are doing the transplant, patient is not secreting any urine on the table. So there is no urine output. So what are the precautions you have to take in the deceased donor program? Can you give fluids liberally like what you do in the live donor program, where there is a large amount of urine being secreted by the kidney?
For dialysis, sir,
He may need dialysis for another 2 or 3 days. Okay, so you have to be very cautious with your IV fluid management. You cannot give fluid liberally like you do in a live donor transplantation. That is one of the important differences in the management of a recipient who is receiving a deceased donor kidney, because the kidney is not going to sometimes function on the table. There may not be normal urine output. So you have to measure the CVP, see what is the fluid status of the patient, and very judiciously and cautiously you have to give the fluids in a recipient in a deceased donor program. Sometimes it may take even 1 week for the kidney to start functioning, because it would have gone in for some amount of acute tubular necrosis, and it may recover only after a week's time. So till then, patient may require again alternate dialysis or even daily small duration dialysis until the kidney starts functioning again. This is a very important major difference between the management of recipient receiving live donor kidney and the deceased donor kidney. Okay. You understand the basics now correctly?
Yes,
Yes,
Ah.
sir.
So when you give fluids in a live donor program, as soon as you see a good spurt of urine, you can start giving your fluids liberally to match the urine output. Whereas in a deceased donor program, because there is no urine output, you have to keep your fluids in a very cautious state. Okay, that is the major difference between the two. Then the next thing is about immunosuppression. When do you start the immunosuppression? You said you will give 0.5 to 1 gram of methyl prednisolone towards the suppression. Soon after the anastomosis release. But is it only given at that time, or should it be given as a pre-medication itself before the start of the surgery? Sometimes they may ask you about these details about immunosuppression and their effect on the interactions with your anesthetic agents. What are the common immunosuppressive agents that are used to prevent organ rejection for any solid organ transplantation?
Tacrolimus, sir.
Tacrolimus one, okay, but commonly cyclosporin.
Cyclophosphamide.
Cyclosporin.
Cyclosporin.
And the steroid. Okay, the Trinity.
Glucocorticoids.
Glucocorticoids is given, and cyclosporin is given, or tacrolimus is given, and this moftil, this what is that?
Mycophenolic acid.
Mycophenolate
mofetil.
moftil. Okay, these are the 3 drugs that are given, and these drugs are given along with your pre-medication 1 to 2 hours before the start of the surgery itself. So patient will be immunosuppressed. So what precautions you have to take during your anesthesia, induction and start of anesthesia? If the patient has already received immunosuppressive agents 2 hours by oral route with this cyclosporin tablet, mycophenolate tablet, and some steroid, everything has been given orally. What precautions you have to take during anesthesia?
Non-depolarizing muscle relaxants will
Non-depolarizing. See, when there is a immunosuppression, what is the basic precaution you have to follow? When you are immunosuppressed, what is the complication you can face?
Infection.
Infection. sepsis.
Asepsis, strict asepsis.
Asepsis.
Okay? So you should not use the same laryngoscope which you have used for a previous case. It should be well sterilized, or it should be a disposable laryngoscope. It should be a disposable tube. It should not be touching the bed or the other areas with your hands. Okay? All strict aseptic precautions in managing the or securing the airway is very, very important. Otherwise, many patients may develop post-operative pneumonia because of the lack of proper sterilization or asepsis during your induction and intubation. There is a chance of post-operative pneumonia, and they should all receive good antibiotic prophylaxis. Okay, so that is the most important precaution that you have to follow because of the immunosuppression agents. And sometimes wrongly given immunosuppression agents, like too much of cyclosporin, that itself can interfere with what function? With nephrotoxic?
Renal.
That itself may suppress the renal function because these drugs are also nephrotoxic drugs. So the nephrologist should know the correct dosage, and the adequate administration of this drug should be done very, very cautiously, so that the drug does not cause any interference with the. Now, with regard to the diabetic control, when a diabetic patient comes for a renal transplant, what is the nature of change that will happen in a diabetic patient when they develop CKD or nephropathy? Will they require the same dosage of drugs that they have been taking right from the start of the diabetic state, or will there be a change in the diabetic medications and requirements? Will they require less dose or normal dose or more dose? I will make it like a MCQ for you to answer or even make a guess.
They'll
If
require
you know
more
the,
dose.
if you know the physiology of insulin, then this question will be easily answered. Where is insulin metabolized and excreted? How is insulin deactivated?
The
It is in the kidney, mesangial
Kidney.
cells of the kidney. Okay. So when there is a chronic kidney disease, the metabolism of the kidney insulin is delayed. It is deactivation is delayed. So whatever the endogenous insulin production has been there in a diabetic patient, that becomes sufficient to metabolize the glucose in these patients. Okay. So they will gradually start getting more sensitive to insulin. And insulin resistance will decrease and they will become more sensitive. And if you continue with the same dosage of anti-diabetic drugs, many patients sometimes may become hypoglycemic also. So they may have to reduce the anti-diabetic medications, both oral and insulin in these patients. That is a very important change that you have to observe in these patients. Okay? And you have to keep them in the correct dosage like this. Okay. Sorry, one second. நான் அப்புறம் பேசணுமா கிளாஸ்ல இருக்கேன். Okay. So that is another important change in the diabetic state that you have to keep in. So intraoperatively, how frequently you should measure the capillary blood glucose level in these patients to prevent hypoglycemia happening?
hardly
Every 2 hours. Normally for any surgery, you have to measure the intraoperative CBG every 2 hours. And why it becomes more important in this patient, in a diabetic patient compared to a non-diabetic patient? What is the type of fluid you are going to use in the recipient?
crystalloid normal saline.
Crystalloid. What type of crystalloid? There are several crystalloids that are available.
0.9% normal saline.
We usually use normal saline. Does it contain any dextrose?
Yes, sir.
0.9% normal saline, does it contain dextrose? No. Why you hesitate so much? 5% dextrose saline has got dextrose and saline. Whereas normal saline contains only 0.9% normal saline, sodium chloride. There is no dextrose. So by measuring the CBG, you can avoid intraoperative hypoglycemia. If the patient's blood level goes to, what is the blood sugar you want to maintain to prevent hypoglycemia?
Less than 180, sir.
181.
Prevent hypoglycemia, not normal. I'm not asking about hyperglycemia. I'm asking what is the lower limit that you have to keep.
120 to 180.
Minimum 80. 80 is
80,
considered
70,
hypoglycemic in any adult patient. And diabetic, sometimes it may be even 90 to 100 will be okay. So you should not allow the blood sugar to drop below 100 in these
100.
patients. In that case, you have to switch over from normal saline to 5% dextrose saline, okay, to bring it back to normal level. In all other patients, we usually try to keep it below 180. But here we have to watch for hypo rather than hyperglycemia in diabetic patients coming for transplant. Okay, that is another small change that you have to keep in mind. Right. So what we have seen is all details about renal replacement therapy. That is hemodialysis, how it is done. All these questions are likely to be asked. Then you have to know the pathophysiology, how the diabetic produces nephropathy. Then the management, the clinical features and preoperative preparation. And elective cases, you should dialyze the patient how much time before the surgery? What is the ideal time?
24 to 48 hours.
Before 24 hours. So after dialysis, within 24 hours, it's ideal to do the surgery. Okay. Whereas in a deceased donor kidney, you may not have this much of time. You may not be having 24 hours time. That is the reason why you do what is called heparin-free dialysis. So what is the purpose of giving heparin for a dialysis?
Blood clotting.
It is to prevent the clot
To
because it
clot.
is going to go through a extravascular structures. It is in the vascular tree. In the how our blood is not clotting when it is flowing in our vascular compartment. This is all about basic physiology of coagulation.
Factors.
Clotting factors. The clotting factors help in clotting. But how our blood is not clotting inside? Basics of coagulation, anticoagulation. There is a balance to be maintained between procoagulant and anticoagulant in our blood. Then only our blood will not clot and completely circulating all the time. Okay. Otherwise, we will develop clot here and there. People who develop clot, it becomes a thrombus, isn't it?
Yes, sir.
So one of the questions asked in the yesterday's paper was venous and arterial thrombosis and embolism. Okay. So what factors are procoagulant? What factors are anticoagulant in our blood?
Clotting factors.
Are all the how many clotting factors are there?
13.
13.
No, they are all proteins, I agree, but how many total factors are there which help in clotting?
8.
13 factors.
13.
Yeah,
Sir.
13 factors. Of course, there some people describe even 15 factors, but normally all the books will give 13 factors. And what numerals are given? Arabic numerals or Roman numerals for denoting the clotting factors?
Roman.
Roman numerals. Why Roman numerals? Well, earlier it was Arabic numerals, like how we write 1, 2, 3, 4, the Arabic system. But later on it became like I1, 2, I3, like that it became Roman numerals. Why? So some confusion between these two. When you say 11, they don't know whether I mean the 2 when there was some confusion in the numbering. Okay, so they changed it from Arabic to Roman numerals. And these 13 factors are supposed to be procoagulant. Whenever you get an injury and you start bleeding, these coagulation factors try to arrest the bleeding. What are all the factors which prevent the blood clotting inside our vascular system? What are the anticoagulant factors which are supposed to keep our blood in a fluid state all the time?
Protein C, yes.
Protein C,
Ah,
protein S, antithrombin
Antithrombin.
E.
There is first and
Antithrombin, sir.
foremost is antithrombin, AT. Okay, then there is protein C, protein S.
Protein S.
Okay, and there is then heparan sulfate. There are these 4 things are called antithrombin or anticoagulant factors. So in a normally intact endothelium and a vascular compartment, these 4 factors only keep our blood in a fluid state. One is antithrombin, second is protein C, third is protein S, and fourth is there is a substance called heparan sulfate. Okay, all these 4 factors only keep our blood in the fluid state. Whenever there is an endothelial injury and there is an exposure of subendothelial matrix, which is the first factor which will activate the clotting to happen?
Factor 2, sir.
What is
Von
factor
Willebrand
two?
factor.
Von Willebrand factor. Is von Willebrand factor classified as one of the factors in the when you describe the clotting factors? We find von Willebrand name along the clotting factors.
Anti-hemophilic factor.
Anti-hemophilic factor. There is factor 8. Okay, so it is a part of the factor 8. It is not enlisted among the coagulation factors, It is a part of factor 8, which is the first one to initiate the process of clot formation in an injured scenario. So whenever there is a breakage of the endothelium and the exposure of the subendothelial matrix, von Willebrand factor only must attract which particular component of the blood to the injured site.
Platelet.
The first sealing agent that will go there. Platelet. Very good. Why you are hesitant? Platelet was helpful. So this attachment of platelet to the subendothelial matrix at the injured site, what is that called? What activity? Huh?
Hemostatic.
It's called adhesion.
Adhesion.
Platelet adhesion.
Platelet
Okay?
adhesion.
Then what happens? Further platelets, when they come and attach itself to form a bigger clot, what is that process called? Aggregation. Okay, this is a very important differentiation between the two things that happen in the platelet activity. Attachment of platelet to the subendothelial matrix, which is a different structural unit. It is called adhesion, platelet adhesion. Attachment of more and more platelets on each other top, that is called platelet aggregation. Okay, so platelet aggregation makes the clot stronger. Platelet adhesion initiates the clotting that is going to happen. Okay, and that is done by what factors apart from von Willebrand factor? What factors help in the aggregation? Once platelets start attaching to themselves to form a bigger clot, which components are released to cause this aggregation to happen? Okay, that's a different topic. Platelet platelet will rupture and it has got a dense granule and a light granule and will release lot of substances, and all your antiplatelet agent activities. You are giving clopidogrel, you are giving aspirin, you are doing newer agents like cangrelor, tecagrelor. All these things are acting on the different components of the platelet which cause the aggregation. Okay, that is how the antiplatelet activity is there. So once you start questioning like this, it can go on to any direction. That is what I want to impress on you. The practical management of these things, it can go on to different directions and ask you to do this. Okay, so to sum up this discussion, if it is a clinical scenario case, you have to first describe how long the patient has been having diabetes, what are all the target organ dysfunctions he has developed, whether it is along with the nephropathy, does he have retinopathy, does he have any coronary problems, so micro and macro angiopathy or peripheral vascular disease, all these things have to be evaluated, and then his cardiac function, because they are known for, will they get any anginal pain even if their coronaries are occluded? In a diabetic patient, even if there is a coronary atherosclerosis and there is a ischemia, will the patient feel the anginal pain or not? Abhirami, Hiranmayi, Saundarya, are you all there?
Yes, sir.
Yeah. So majority of them, they may not feel the pain. It is called silent ischemia. Have you not heard of that term? So diabetic patients are more notorious for developing silent ischemia because why they don't feel the pain? It is another sub question that can be asked. What change in the nervous system produces lack of pain? Autonomic neuropathy. That is the most important change or complication of diabetes. Okay, that is the reason why they may not feel the pain. Okay, so all these things have to be evaluated, and you have to ask the important history of what is the weight gain between two dialysis. That is a very important thing to ask, because that will tell you whether the patient is following the instructions of restricted fluid intake or not. Otherwise, they will. And another important question, whether they had any dialysis disequilibrium syndrome during the initial stages of dialysis, which shows their vascular hemodynamic instability. And the third point you have to ask about the dialysis is whether they have developed any signs of fluid overload like pulmonary edema when they missed 1 or 2 dialysis due to some reason. They have gone out for a function and there was no dialysis facility in that area. They thought they can come back to the hospital, but the train got delayed or some reason. Have they ever had features of fluid overload or impending pulmonary edema by missing a dialysis due? So these 3 questions you have to ask. What is the weight gain? What is whether they had any disequilibrium syndrome? And third, whether they had any impending pulmonary edema by missing the dialysis. Okay? All these questions that you have to ask. And all about control of diabetes, how they were taking the medications, how frequently they were monitoring themselves. And then once they have gone on to the dialysis, the disease donor program. Another important question that may be asked is how to manage the deceased or brain dead donor for harvesting the organs. That is another separate topic itself that can be asked in the theory exam also. Discuss the anesthetic management of a brain dead donor for organ donation, and some questions that may be asked in your practical exams also. Supposing you are the anesthetist for the brain dead donor, what are all the, just tell me a few points which you have to keep in mind while anesthetizing. Why they require anesthesia? First question. Why a brain dead donor who is supposed to have a, what is the definition of brain death?
Cessation of
Irreversible consciousness and irreversible ability to breathe. Very, very simple answer. Okay. Irreversible consciousness and irreversible ability to breathe. That is why we do the apnea test, whether they are really apneic or not. Okay. So irreversible loss of consciousness and irreversible loss of ability to breathe, then you declare a patient as brain dead patient. Okay. So when they have this consciousness lost, why they require anesthesia? As they are already unconscious. Then what is the reason for giving? Somebody is typing in the chat box to prevent the
spinal reflex.
They have to prevent the spinal reflexes, which is a very important thing. Otherwise, there may be certain jerky movements in the limbs and all that, because there is a stimulation that can be routed through the spinal cord without going to the central nervous system or the brain. Okay, right. And what are all the important parameters you have to maintain in the deceased donor? When you give anesthesia to the deceased donor for organ donation, what all? Tell me a few important parameters that you have to maintain very correctly. What is the rule of 100?
BP of more, systolic BP of more than 100.
More than 100.
HB of 10 gram per
10
deciliter.
grams per deciliter, very good.
And
PO2 of 100.
Glucose of more than 100.
Okay, these are the 4 things. And temperature is very, very important.
Urine output.
Urine output of 0.5 to 1. Unless they have been diagnosed to have diabetes insipidus earlier. Otherwise, they should have this thing. Very good. So these are all the points that may suddenly they be asked in the practical exam also. So a few points that you have to remember. And the problems of reperfusion that we were discussing, we suddenly digressed to some other else. What are the things that you have to look for as soon as the clamp is released and the kidney gets turgid and pink and urine starts coming? Yes, what complication can happen because of the preservative solution, which will go into the recipient circulation?
Hypotension.
Hypotension is one. Very good. Okay. Sudden release and diversion of a lot of blood into the kidney can produce hypotension. Excellent. Any other electrolyte imbalance and its complication? I told you one electrolyte is important in the preservative solution to
Hyperkalemia. sir.
hyperkalemia. Excellent. Because the potassium content of the preservative solution is more, you have to watch out for signs of hyperkalemia.
Hyperkalemia.
Supposing as soon as the clamp is released and you find the ECG showing a tall T wave and it goes in for something like a ventricular tachycardia, what will you do?
Retina shock.
Immediately shock. The cause is hyperkalemia. You know that. So how do you manage the acute
Insulin.
hyperkalemia? Huh? Will insulin immediately bring down the hyperkalemic state?
No, sir.
Huh. Management of hyperkalemia is a theory question also.
Dialysis.
Dialysis on the table, man. This is during surgery, it is happening. Clamp is released. Immediately the kidney becomes turgid and pink. There is some urine output, but at the same time, the heart rate starts shooting up. You look at the ECG monitor, there is a tall T wave. ST elevation.
Calcium gluconate.
That is the emergency treatment. You counterbalance that hyperkalemic state with 10 ml of calcium gluconate IV. That is the answer that is expected, and that is the practical thing that you have to do. And immediately send the blood for ABG to find out whether the patient is in acidosis also, which could have aggravated this hyperkalemia. Or your ventilation may not have been properly done, or your soda lime could have been exhausted, and patient could have gradually developed an acidosis. So immediately send a blood sample for ABG and see whether the patient is in acidosis, which could have already triggered an endogenous hyperkalemic state. Along with that, the preservative fluid potassium also comes into that. That is the reason why they suddenly develop an acute hyperkalemic injury. Okay, so that is the question that you have to keep in mind. And so hypotension and hyperkalemia are the two complications of clamp release and reperfusion. Okay, that is the answer that you have to remember. And of course, finally, the surgery is completed by attaching the ureter to the bladder, causing, what is that step called? Attaching the ureter of the transplanted kidney to the bladder. What is the name for that procedure?
Uretroneocystostomy.
Very good. Neocystourethrostomy or uretroneocystostomy, and then the urine output is monitored so that you can replace fluid according to the fluid loss. And of course, post-operatively, barrier nursing is important again because these patients are immunosuppressed, and the immunosuppression will be continued in the post-operative period. And you have to keep a watch on the glucose level, give adequate pain relief, give adequate antibiotic cover throughout the post-op period, ambulate them as early as possible to prevent any deep vein thrombosis and thrombosis occurring in the transplanted kidney also. Okay, so these are all the things that you have to keep in mind. So already we have come to 7 o'clock. So I will stop with that. Now, any questions or any doubts on this?